Welcome to Health Talk. Thank you for joining us at the studio audience and beyond. We're very happy today to have with us Dr. Marc Zare, a bariatric surgeon, and we're going to talk about gastric sleeve and all you need to know. And Dr. Zare is board certified general surgery, and he's fellowship trained in laparoscopic surgery and bariatric surgery. So, Dr. Zare, gastric sleeve is the most commonly performed weight loss surgery today, and tell us a little bit about it and what is it that we need to know.
Thank you, Gloria, for inviting me back on your show. Gastric sleeve is a type of bariatric weight loss surgery. It's probably the most common, most popular one that we currently offer. The concept of bariatric weight loss surgery is to help people lose significant weight. We're talking about 80 to 100 pounds, and be able to keep the weight off. That's the sort of the background. There are many different procedures we've done over the years, and we have now finally come up with a procedure that we're truly excited about. We can offer it to patients with fairly high certainty that it's safe, it's effective, and the weight loss can last with them. We call it sleeve gastrectomy or gastric sleeve. It's not because we, as some people think, place some sort of a foreign sleeve inside your stomach or anything like that.
Oh, draw us your diagram.
Yes,
I want to see this.
I personally would have called it a banana gastrectomy because that's what it really looks like. So what we do in a gastric sleeve is if you take your normal stomach, it looks like a big sack. And it has a fairly large capacity, right? So the idea here is to reduce the capacity of the stomach by dividing it into two portions and removing the large portion. So what we do is we take the left side that you see on the screen and we separate that from the remainder, effectively reducing the size of the stomach to about 4 to 5 ounces.
So this part is removed.
Yes. So the net result is that you have a stomach that really looks like a sleeve of a jacket or a banana, right? And that is what we leave behind for the patient.
So that's the new stomach, the skinny banana-like looking structure.
Correct. So gastric sleeve is effective because of many reasons. What we do here is we reduce the size of the stomach, and we use the left side, technically the right side of the anatomy, but you can see it on the left side of the screen, because this portion of the stomach, as opposed to the other opposite end, is very thick and muscular, and it doesn't quite expand easily.
And it won't flip around.
Won't, yes. So what we do is during the procedure we place strategic sutures to keep the sleeve in place so it doesn't move, and it really becomes a very stable structure, and it really limits one's capacity for big meals. But that's just the starting point. What this operation also does is, because we remove that 70 to 80% portion of the stomach, we actually change a lot of hormones that your digestive system normally makes. We're talking about hormones that influence your appetite, hormones that influence that sense of fullness and satiety, and very importantly, hormones that contribute to a normal blood sugar and control of diabetes. We have actually learned that this is really a incidental benefit of these procedures. As we were designing a lot of these procedures, and it's the predecessors to the sleeve, the concept of influencing metabolism wasn't even in place. We learned through the years that by altering anatomy and reducing size and so on, we actually end up influencing diabetes and other conditions through hormonal pathways, and that's been a really interesting finding.
Some people, have we seen on television shows, you know, how to be the biggest weight loss person on television show, win a prize. Now, some people have been obese or overweight for many years, and people have to understand that losing weight is very difficult. Everyone should know that. And once one attains a certain level of weight and hard to lose that weight, some people are still afraid to have surgery like this.
Correct.
However, this has been shown to be safe, and you make 5 little holes in your abdomen and 1 more for viewing. And so the little holes are probably 1/2 an inch.
That's right.
And so through that, they are able to remove this stomach, this part of the stomach, and remove that and take it out. And what does the patient then expect post-op? What?
Correct. So as you correctly described, the procedures are done through 4 or 5 little holes, and these are called laparoscopic incisions, as opposed to the big incision that obviously has unwanted side effects of pain and wound complications and so on. Because of those small incisions, patients can really expect to have a fairly predictable post-operative recovery of about 1 night in the hospital. We send patients home typically the day after surgery in the afternoon. They can expect to have a recovery of about 1 or 2 weeks, during which time they easily come off strong pain medications, transition to simple Tylenol. They are independent, they're walking, they're going out, spending time recovering, and feeling like they're ready to get back to work, typically by 1 or 2 weeks.
So the first 2 days they eat clear liquids, like tea, bouillon, and then the 3rd and 4th day, milk and yogurt?
So yes, so there's some variation among surgeons as to how quickly or how slowly one advances patients' eating and diet after surgery. And the bottom line is, because we create a new stomach with a staple line that needs to heal, we take our time before we feed patients solid food. However, because the procedure was done through laparoscopic approach, it's really not a big stress on the body. So you can easily tolerate liquids the same day. Literally, as soon as you open your eyes, you're able to drink. And so that's the diet or eating style of the first week. It's generally liquids of different consistencies, and you then advance after 1 or 2 weeks to food that's processed and blenderized, and then gradually you go on to eat softer foods and regular food.
So it would be clear liquids, then thicker liquids like milk and yogurt, and then processed mashed food like mashed potatoes or blenderized food?
Well, you
Or
just use 2 words that are kind of
different.
no-no words we don't like.
Okay.
One is processed and the other one is mashed potatoes. But I think your thinking is absolutely correct. By processing, I think you mean blenderizing,
Right.
and absolutely that's the key to that phase, is to chop the food and blenderize it so that it's pureed as opposed to actual particle, big
Right.
components. Potatoes, carbohydrates, sugars, those are the problem foods
Right.
that contribute to weight gain to begin with.
And for diabetics,
So especially diabetics.
who are seeking this.
Correct.
Yes.
And so in our education, we teach patients that when they've had this procedure, their main focus after surgery should be proteins, vegetables, and only then, if there's space, carbohydrates such as bread and mashed potatoes. So when you go through that cycle, you realize that the foods that are the most important fill you up so quickly that there won't be much space for carbohydrates, and that
Right.
becomes the new routine for many of our patients.
So even contemplating this to get insurance pre-authorization, because insurance does cover it, but the pre-authorization is like typically 6 months, where you
Yes.
see an internist, check in, and that you actually tried to lose weight and diet
Correct.
conventionally,
Yes.
rather than this.
So yeah, we are lucky in this, in that most insurance carriers do cover the procedure. However, they don't make it easy for patients, and there's clearly a need to take one's time and make sure that the patient is an appropriate candidate, he or she understands all the details of the procedure and recovery and lifestyle that has to change. And then during that period of evaluation, we we, we make use of the other providers such as dietitians, mental health specialists sometimes, internal medicine, and some specialties. If patients have had heart problems, we send them to cardiologists and get a full evaluations of their heart. The process can sometimes take up to 6 to 8 months. We try to be as efficient as we can. The whole idea is to support patients because they have been through a lifetime of excess weight. They don't like the idea of yet another 9 months of wait. And so we try to be as efficient as possible. We have several providers that we work with, and so the network is in place for them, lots of support elements, and once that's completed, then we proceed.
Now, if, let's say I'm diabetic and I'm pre-diabetic, but suddenly the blood sugars keep spiking and my internist tells me, and I'm 100 pounds overweight, so I've reached the BMI of 40 or 35, which is the cutoff, and I'm at risk of becoming a diabetic. So then I have this procedure, and then I have all my medications post-op. So when do I see my internist to figure this out?
So really,
my insulin or whatever.
Correct, good question, and then that's a very common question I receive in my practice. You really, one has to see one's physician before surgery, so you have a plan in place. Many of our diabetic patients have several medications for diabetes. What is very almost magical about the procedure is that sometimes even before the patient leaves the hospital, they see their blood sugar going down significantly, and that's because of the hormones have changed. Hormones such as GLP-1, which is an incretin, it helps insulin do a better job. The change is instantaneous. It's not related to weight loss, and so knowing that, you really have to anticipate and be ready for a diabetes of 10-20 years to melt away and be gone within a few days. Of course, sometimes it takes longer, and in many patients it takes up to 6 months. During the first 1 or 2 weeks, up to 6 weeks, it's crucial to keep an eye on the blood sugar, make sure that you're not over-medicating, and as you taper off medications, you need the help of your physician to be able to tell you which one goes off first, and so on.
So this is done with close teamwork.
Yes.
So you see, if I am diabetic, pre-diabetic, and I have issues of being overweight for many years, I would have seen my internist before, obviously in the 8 months before, to do the dietary changes, and then we have a schedule as post-op when I see him, probably within the first week or so.
Correct.
And I think that my own patient population, because I see many diabetic eye patients, they've maintained their weight loss and their diabetes becomes gone. I mean, significantly better or gone. So tell us a little bit about that.
Yes, so the whole idea here is to influence one's weight, but at the same time improve the health portion. Specific to diabetes, we have done some good studies prospectively evaluating diabetes and its resolution following the surgery and comparing it to, let's say, aggressive medical treatment. One of the best studies done followed patients up to 3 years, and they found that on average, sleeve patients reduced their hemoglobin A1C, which is the blood measure of how well your diabetes is controlled, by 2.5 points. They started at about 8.5, and they ended up at about 6, which is considered a normal number. Compared to patients who simply took medications, maybe increased their medications, and there was only less than half a point difference at the end of that study for those patients. So there's a big difference in how effective this intervention is for diabetics compared to just being on insulin or oral medications for diabetes.
You know, diabetes is a $57 billion year problem for Medicare and all the insurance payers. So also, as a diabetic, some do not know that this is available, because sometimes many internists do not refer them to a bariatric surgeon. And maybe there are misconceptions that they don't know how safe it is or what the long-term gains. Tell us a little bit about why is it so safe? Because, you know, physiologically it's the same.
Correct. So that is really one of the best chapters in the history of surgery, modern surgery. If you look at what we've been able to achieve throughout the years with some big events that occurred in the last 100 years, availability of blood transfusion or organ transplantation or heart bypass and all these big events in surgery, probably the most recent big event was introduction of minimally invasive and laparoscopic approach, which allows us to perform these complex procedures through these very small incisions. That was a big leap forward. It occurred in the late 1980s, and since then we have actually been able to improve the outcomes by 10 to 20 fold, which is a huge number if you put it in the context of other interventions in medicine that might improve an outcome by 5 or 10% at best. So you take that.
So you mean improving outcome in terms of maintaining weight loss?
Well, no, not even that. That then goes back to the actual procedures and how effective they are. But
You
just
mean
being able to undergo procedures without complications relating to infections or bleeding and so on.
wound dehiscence?
Exactly, and length of stay in the hospital. Let's take the biggest complication, which is mortality, right? As we know, any operation can be potentially associated with death. It used to be that in my training days in the late 90s, bariatric surgery as a whole was considered to be safe, but it had a mortality rate of about 2 to 3%. For many patients of excess weight who have diabetes, kidney issues, high blood pressure that's resistant, and so on, that was an acceptable number still, because otherwise they had a dim outcome by just their status quo. Fast forward to 2018, our mortality rate is now less than 0.1%. That's a 30-fold.
With this procedure?
Correct.
Wow.
That's a 30-fold increase in our ability to perform these procedures safely without concerns about mortality. And by that, we also have improved all the other outcomes that have come through the years with bleeding, infection, wound complications, and so on. So it's really a very safe intervention, equally at par with removal of the gallbladder that has a mortality rate of about 0.1%.
So this is 0.1%?
0.1%.
So it's the same as gallbladder?
Same as gallbladder surgery.
This
And
is
if you look
excellent.
at how frequently then people who know about these, how frequently this operation is being offered, it's as frequent as people's appendix being removed in this country. Appendectomies occur in about 300,000 or so in every year, and that's about the number of bariatric procedures we do these days. So it's prevalent, it's safe, and then most importantly, it's done to improve health conditions that otherwise don't really have in many cases, an effective medical option. Talking about diabetes, resistant diabetes, high blood pressure, and so on, which in and of themselves, each one of them can then lead to other organ damage and organ failures. And so the spectrum of conditions that one can influence with an hour-long procedure all of a sudden is quite unbelievable, and that's what we see every day in our practice.
So there is a huge, demographic shift as people are becoming more and more overweight, and a big trend towards type 2 diabetes, even in adolescence. And so there is possibility for room to grow for this procedure, because I think a lot of people don't know that it is safe, so safe.
Yes, and that's the unfortunate part of it, is that for every 1 or 2 patients that undergoes bariatric surgery, there's about 98 or so out there who qualify and could benefit from it, but don't receive it. So we only reach, as bariatric surgeons, we reach about 1 or 2% of potential candidates who have excess weight, who have the medical problems that go with that, and just are not made aware in a lot of times of their options.
So in my own practice, I've had patients who have undergone this, and the change has been miraculous. Seeing the metabolic changes, that they're no longer diabetic and their hemoglobin A1C is 6. And they also change, their whole appearance changes. They're no longer overweight, they can now bend and touch their toes, they can climb the stairs, simple things which they had issues with doing.
Absolutely.
Tell us a little bit about that. When people see you, what are their major complaints?
So I believe in really putting patient out at the center of this process. I really think that knowing their goals is really a good starting point, and keeping an eye on that goal throughout the journey is very important. So I always ask patients, what do you want out of this procedure? And a lot of times I'm touched by how simple some answers are. We as physicians think their answers should be, you know, I want to get my A1C level to a 6 or get my blood pressure under 110. But a lot of times it's all about quality of life. I want to be able to play with my grandchildren, or bend and tie my shoelace, or fit in a regular seat in an airplane. And those are very important outcomes, important goals that we as physicians should keep in mind. And I'm really happy when I see my patients and hear how we've been able to achieve majority of those goals. It explains why they're so happy.
Now, part of the success rate over the years is that the instrumentation has improved. I'm sure the laparoscopes in your training 10 years ago are different now.
Yes.
Tell us, have they become smaller? Are the cameras better?
Yes, so what we do in the field of minimally invasive surgery is, in a way, it's like playing video games all day long. It's really a fun field in surgery. We use a lot of technology. We use, as you alluded to, we use cameras that capture images and project on a high-definition screen with magnification. So we have typically a 3 to 4 fold magnification on a high-definition screen, so we can literally see every vessel, every structure, in ways that sometimes it's really difficult to see through an open approach with organs on top of each other. The instrumentation that we use is also a lot more advanced. The sleeve gastrectomy is done via essentially a staple line. You can staple across the stomach with permanent titanium staples. You can think about them like the sewing of a jacket, very fine 3 rows, and they've come a long way. We used to have staple lines that were 2 rows. They would bleed. They would have issues down, afterwards. But they are very strong, very reliable, and we don't really think twice about using them or wonder if they work.
I like the video where you showed me where you invert the suture line.
Yes.
So the suture line is on the inside of the stomach, so that all the other organs never rub on the suture line.
So there are lots of things you don't see in this drawing, but as we create a sleeve, we have the staple line that goes this way, and everything else is one's own tissue. This has to heal, and that's why we don't feed patients right away. But there's definitely a need for us to make sure that there's no adverse event. And so by placing some strategic sutures along the staple line, many of us feel that we are helping the healing process and avoiding issues like you point out. So we place certain sutures in the top portion to make sure that the staple line is inverted, to strengthen that area, and very important sutures to what we call pexy, or fix the sleeve in place, so that as soon as you start eating, the waves of muscle contraction that push the food through don't incidentally create a pretzel out of the sleeve. And so we like that the anatomy to stay as such.
Oh, now, let's say I am 300 pounds overweight.
Yes.
So we're talking about maybe a 600-pound man or woman, something like that. Using the 5 instruments is very good because you don't have to worry about wound dehiscence, a big scar, just doing that small thing. But I'm sure for people who have this much weight loss, this is still successful. But tell us what are some things that are worrisome versus losing only 100 pounds versus 300 pounds.
So there are a number of issues that we pay attention to. As you lose weight in the first 6 to 12 months, you are at increased risk of developing gallstones, for example. We know rapid weight loss can induce that. But fortunately, in modern medicine, research studies are constantly being performed. So about a decade or 2 ago, we identified a medication that helps reduce the incidence of developing gallstones from about 30% down to about 2 to 3%. So we place patients on a medication during that period so we don't have to worry about gallstones. As you lose weight, majority of changes are positive changes. We talk about improvements in musculoskeletal aches and pains, improve energy, and of course resolution of diabetes and other medical problems. There's this other psychological event that's occurring in patients that we sometimes as physicians take it for granted to be always positive because they're losing weight and health's improving, but an individual who's lived at 600 pounds is used to that psychology of being at that weight. And so we really have to be cognizant of the fact that there are stresses along the journey. As they lose the weight, they may require additional help to cope with these changes and re-identify themselves as someone who is much lighter.
So there's a mental health aspect that
A big one,
yeah.
yes.
And I know that there are specialized bariatric nurses to help you with that. We're getting near the end of the show. Let's sum up. I think for the take-home message for gastric sleeve is that number one, it's safe, that it is the complications 0.1%, the same as a gallbladder, much improved from 50 years ago. And that insurance will cover it, and that there's a long period of counseling with your internal medicine doctor, with mental health, with your bariatric surgeon, and there are 5 small incisions, about ½ an inch, and see Dr. Marc Zare's website where there are videos, and also there are other videos. So thank you so much for having, explaining all this and being on our show. And for our home audience, if you like the show, donate to KSAR Television and, give us a Facebook like and visit Dr. Zare's website. And thank you very much for joining us.
Thank you, Gloria.